Trauma overview. The National EMS Education Standard competencies for this trauma, things that we need to understand. Trauma applies fundamental knowledge to provide basic and selected advanced emergency care and transportation based on assessment findings for an acutely injured patient. We will look at pathophysiology for various various mechanisms. We look at assessment and management of trauma patient. We look at trauma scoring, rapid transport and destination issues, and transport mode. We'll be looking at multi-system trauma, which includes recognition and management of multi-system trauma, pathophysiology, assessment and management of multi-system trauma, and blast injuries. Introduction. Unintentional injury is a primary cause of death and disability in people between ages 1 and 44 years. Proper pre-hospital evaluation and care minimize suffering, long-term disability, and death from trauma. So the pre-hospital component is important to a trauma patient. That is critical. If that's absent, the chance of recovery is limited, and these patients will have disability, or it can lead to death. Evaluation of the mechanism of injury for the trauma patient will provide you with an index of suspicion. Energy and trauma. Traumatic injuries occurs when the body's tissues are exposed to energy levels beyond their tolerance. So when energy is applied to the body in the form of force, if the body is not able to dissipate the force, it results in energy. Results in soft tissue injuries. The more concentrated this energy is, the more severe the injury will be. High energy injuries often produce severe damage. Different forms of energy produce different kinds of trauma. So we have kinetic energy, which is energy in motion. Kinetic energy reflects the relationship between mass, which is the weight of an object, and velocity, which is speed in any direction. And the formula is kinetic energy is half times mass times velocity squared. The speed has greater effects on the force of energy than the size of the object. So speed greatly increases force. Potential energy is energy stored in an object. Chemical energy is released as a result of a chemical reaction. So there must be a chemical reaction for chemical energy to occur. Thermal energy is energy transferred from sources that are hotter than the body. Barometric energy can result from sudden or radical changes in pressure. So barometric is associated with pressure. Mechanism of injury profiles. Different types of MOIs produce many types of injuries, and an MOI can be specific or it can be diffused. If it's specific, usually the injury is not severe, but it can be. If it's diffuse, usually the injury is very severe and the patient is at risk for multiple trauma. Injuries sustained by trauma patients may be the result of multi-system trauma, falls from heights, motor vehicle and motorcycle crashes, gunshot wounds, and stabbings. Maintain a high index of suspicion for serious unseen injury. So the mechanism is what causes the injury. The index of suspicion is the worst possible injury you think the patient might have from that mechanism. Blunt and penetrating trauma. Blunt trauma, injury primarily without anything penetrating the soft tissues or internal organs and cavities. Penetrating trauma, injury by objects that pierce and penetrate the surface of the body. Either type of trauma may occur from a variety of mechanisms of injury. Let's focus specifically on blunt trauma now. Results from an object making contact with the body. The two most common mechanisms of injuries for blunt force trauma is motor vehicle crashes and falls. Maintain a high index of suspicion during patient assessment for hidden injuries. Again, the mechanism of injury is what caused the injury. The index of suspicion is the worst injury you can anticipate based on the mechanism of injury. Blunt trauma, motor vehicle crashes. Within a motor vehicle crash, there are three collisions, three primary collisions. So there are various types of motor vehicle crashes, but within these motor vehicle crashes, three primary collisions occur. The first collision is the collision of the vehicle against another vehicle, a tree, or some other object. So something stops the vehicle from moving. When we think about the first collision, we're thinking about access to the patient. So when you think about the first one, it's really access we're thinking about. Will we need certain resources on scene to gain access to this patient? And also look at how badly damaged the exterior of the vehicle is. That will give you an idea of how much force has been transferred to the patient. The second collision is the collision of the passenger against the interior of the vehicle. So the car is going at 120 miles per hour. It's a light post at 120 miles per hour. That's the first collision. The second collision, the body travels at 120 and hits the interior of the vehicle. When we think about the second collision, we're thinking about external injuries to the patient. So the second collision is really external injuries we're thinking about. Why is the windshield, why does the windshield has a spider web? Why is the steering deformed? Why is the dashboard deformed? Where on the patient caused that to occur? So you're thinking about external injuries. The third collision is when the organ travels at 120 kilometers per hour or miles per hour, whatever the value is, and hit the internal areas of the body. Now, when we consider the third collision, we're thinking about internal injuries. So to zone in on your third collision, you need to look at the patient for impact points. Impact points on the patient. Is there bruising on the head? Is there bruising on the chest? When you start to see signs of impact, think about what is underneath that area. That's your third collision. So third collision is internal injuries. Now let's look at the different types of motor vehicle crashes. So you have frontal crashes, understanding the MOI after involves evaluation of the supplemental restraint system. Determine whether the passenger was restrained by a full properly applied 3-point restraint. Do you have a question, Miss Mitchell? Miss Mitchell, do you have a question? Yes?
Sir.
All right.
No, sir. No, sir.
All right. You keep hitting the hand icon, so avoid doing that.
Okay.
Mute your mic. Determine whether the passenger was restrained by a full properly applied 3-point restraint. Now, contact points are often obvious. Persons that are tall tend to go over the steering or over the dashboard. Persons that are short tend to go under the steering or under the dashboard. Remember, when you're looking at the interior of the car and there's deformity, we're thinking about external injuries. When we're looking at the patient for impact points, that's when we start to think about the third collision, internal injuries. So the patient can have fractures at the lower extremities, they can have spinal complications, they can have head trauma, they can experience what we would call the paper bag effect, where they take a deep breath, the glottic opening closes, and the chest makes contact with the steering and ruptures the membrane around the lungs, causing a pneumothorax to develop. And this is the most common mechanism for a tension pneumothorax, paper bag effect. Rear end crashes causes whiplash type injuries, and rear end collisions are the only collisions that are caused by accelerating forces. All the other all the other motor vehicle crashes are caused by deceleration forces. And rear end is associated with whiplash. Patients can also get whiplash from lateral crashes as well. So lateral crashes cause lateral whiplash injury. Patient could experience rotation of the neck, lateral flexion, or a combination of both. Rollover crashes and rotational crashes are the most severe because these are the motor vehicle crashes that multiply the 3 collisions that occur within a motor vehicle accident. Any crash that multiplies the 3 collisions would be the most severe. So rollover crashes, most common life-threatening event is ejection or partial ejection of the passenger. And with your lateral crashes, one of the common injuries that can be life-threatening is a aortic tear or shearing of the aorta, or it is torn. Is common with lateral crashes. Rotational crashes, this is another crash that multiplies the 3 collisions, so it can be quite severe. Injuries are a combination of frontal and lateral impacts. 3-point seat belts are effective in preventing injury. Vehicle versus pedestrian crashes. 3 phases of impact occurs with these type of accidents. Vehicle and pedestrian impact occurs. So vehicle makes contact with the pedestrian. The pedestrian rotates onto the hood. The pedestrian rolls off onto the ground. The injury pattern depends on the height of the pedestrian and the body area facing the impact. Vehicle versus bicycle collision. Evaluate the MOI in the same manner as vehicle versus pedestrian crashes. Motorcycle crashes. Patients should undergo cervical spine assessment. Types of motorcycle impacts include head-on crash, angular crash, ejection, and laying the bike down. Falls. Falls greater than the height. Greater the height, the greater the height of the fall, the greater the potential for injury. And when we consider falls, we need to think about the distance that the patient fell from. Did they make contact with anything before hitting the surface? Which body part made contact and what type of structures are underneath that area? Falls 3 times an adult height is considered significant. For pediatrics, it's 2.5 times their height. If a patient falls from a standing position and loses consciousness, that is considered to be a serious fall. So the greater the height of the fall, the greater the potential for injury. Internal injuries pose the gravest threat. Take into account the height of the fall, type of surface struck, the part of the body that hit first, the area of the body over which the impact is distributed. Now let's look at penetrating trauma. Can be classified as low energy, medium energy, and high energy. Low energy penetrating trauma may be caused by impalement or a knife, an ice pick, or other weapon. Point blank and high velocity gunshot wounds results in more significant injuries. So medium energy and high energy is associated with handguns, rifles, shotguns. The angle or direction of travel is also pertinent. First, determine the number of penetrating injuries, then combine that information with what you know about the potential pathway. With gunshot wounds, fragmental bullets increase damage due to multiple fragments. Hollow point bullets expand as they enter the target. Full metal jacket bullets cause less damage than fragmented rounds. The bullet speed is a major factor in resulting injury. So the speed of the bullet has greater influence on the force and therefore the significance of the injury. Cavitation results from rapid changes in tissue and fluid pressure, and You can have temporary cavitation, which is cavitation that occurs from the pressure wave generated by the bullet, and permanent cavitation, which is the path that the bullet takes when it goes through the body. Relationship between distance and severity of injury varies depending on the type of weapon involved. Exit wounds are often much larger than entrance wounds, and bullets can enter, hit bones, and be redirected or ricochet to somewhere else in the body. Blast injuries. Blast injuries most commonly associated with military conflict, also seen in civilian practice in the industrial setting and in drug labs, illegal drug labs. Primary blast injuries entirely due to the blast itself. Damage to the body caused by pressure wave. Proximity to the origin of the pressure wave is associated with the highest risk of injury or death. So, explosion is when a solid, liquid, or gas is rapidly heated and it expands. Miss Mitchell, mute your mic, please. Mute your mic. No, the primary blast is really the pressure wave that is generated by the explosion. Closer the person is to the pressure wave, the more severe the injury will be. Secondary blast injuries result from being struck by flying debris. Projectiles present serious hazards. This is the shrapnel, the debris that is thrown by the explosion. May cause blunt and penetrating injuries. The tertiary blast injuries occur when a person is hurled by the force of the explosion against stationary, rigid objects. Injuries result from both blunt and penetrating mechanisms. So the primary blast is associated more with pressure or barometric trauma, and the secondary and tertiary blast injuries are associated more with physical and internal injuries. Blunt penetrating. Quaternary miscellaneous blast injuries result from miscellaneous events that occur during an explosion. Heat generated during an explosion may cause burns. Quinary blast injuries are caused by biological, chemical, or radioactive contaminants added to a traditional explosive device. Additional long-term damage through biological, chemical, or radioactive mechanisms may occur. Tissues at risk. Organs that contain ear are more susceptible to barotrauma. Tympanic membranes can help determine the possible presence of other blast injuries. So damage to the tympanic membranes, right? Patient is having issues with hearing or balance after an explosion, then you should be thinking about blast injuries. Pulmonary blast injuries result from short-range exposure to the detonation of explosives. Pneumothorax is a common injury and may require emergency decompression. Multi-system trauma. Injuries of a person who has been subjected to multiple traumatic injuries involving more than one body system. Provide rapid treatment and transportation, alert medical control. Golden principles of pre-hospital trauma care. So 1, ensure that the scene is safe. Determine the need for additional personnel or equipment. Evaluate the MOI. Form your index of suspicion based on the MOI. Identify and appropriately manage life threats. Assess and manage the airway. Ensure that basic shock therapy is completed. So with trauma, the goal is within the first 6 minutes, life threats must be addressed. You want to limit your unseen time to less than 10 minutes if the patient is critical. You will seal puncture wounds or penetrating wounds. You will stabilize impaled objects. You will control bleeding if it is present. You will splint fractures. You will consider spinal motion restriction, and you will consider keeping your patient on a cardiac monitor if they are critical, establishing IV access for the purpose of fluid resuscitation. If you're considering fluid resuscitation, if you suspect internal blood loss, then your goal is not to normalize the patient's blood pressure. So if the patient is bleeding internally, the fluid resuscitation is done to maintain a systolic of 90 to 100. You don't want to normalize the blood pressure because that can cause clotting factors to be diluted. If the patient has signs of raised intracranial pressure and you suspect shock, then you don't want their blood pressure to go down to the lower ends. We try to keep their blood pressure closer to the normal end. So that's for your head injury patients. So you're looking at a systolic of 110 to 120. Patient with a head injury should not have a systolic below 90. That is not good for their brain. If you suspect distributive shock is present, which an example of that would be a patient with neurogenic shock, patient is going to need a lot of fluid, up to 2 liters. They may also require vasopressors. Vasopressors would be outside the scope of an AEMT. So if it's required, paramedics would administer it. Outside of what I just mentioned regarding the various presentation, regardless of the route of fluid resuscitation that you're taking, regardless of the route you're taking, whatever amount of fluid you decide to administer to the patient, it should be incremental. So regardless of the amount, you give it in increments of 500 mils. And some protocols will say to give it in 250 mil increments, especially for a geriatric population. What that means is after each increment or bolus of 500 mils, you will evaluate the patient's mental status and peripheral pulses, look at the mean arterial pressure, and you don't want a mean arterial pressure below 65, and you don't want a pulse pressure below 40. Outside of that, you're guided by protocols. Follow your protocols. So your fluid resuscitation can be the 3-to-1 rule. For every mil, you give 3 times that amount. It can be based on the patient's body weight, 20 to 30 mils per kilogram, probably half that amount for your pediatric population. And it can be bolus administration, incremental. So ensure that basic shock therapy is completed. Rapidly proceed with spinal motion restriction if it is indicated. During transport, obtain sample history. For critically injured patients, consider paramedic intercept or air medical transportation. Patient assessment. Identify life-threatening illnesses and injuries as soon as possible. As soon as possible improves patient outcomes. So the faster you can identify life-threatening problems and deal with them, the better the patient's chance of survival. Our goal is to manage all life threats within 6 minutes, and we want to limit our unseen time to less than 10 minutes. In order for this to be possible, you need a efficient team. You need a good team on scene with this patient. A trauma patient that is critical, that is not responsive, usually doesn't have a good outcome on scene. So if they're in respiratory arrest after a traumatic injury or cardiac arrest, their outcome is very slim. For them to have the best chance of survival, a proper response team is needed. Life threats need to be addressed in a timely manner. The goal is less than 6 minutes, and we want to limit our unseen time to less than 10 minutes. Assess, triage, treat, and transport patients with traumatic injuries to the most appropriate facility. And the most appropriate facility might not necessarily be the closest facility. Injuries to the head. Disability and unseen injury to the brain may occur. Bleeding or swelling inside the skull from the brain injury is often life-threatening. Again, these patients, if you need to do fluid resuscitation, we don't want their blood pressure systolic to go below 90. And I would say you want a systolic of 110 to 120. Injuries to the neck and throat. Injuries may result in airway problem. DCAP BTLS is going to be important for these patients. Always use an occlusive dressing on any open neck wound. You will be guided by your protocol where that is concerned, because some protocols will have occlusive dressing for the neck, some will not. So you're guided by medical direction and protocol. For these patients with neck and throat injuries, you definitely need to be thinking about advanced airway management. So if your basic airway is not sufficient, then you need to be considering an advanced airway. Injuries to the chest. Blunt trauma to the chest can fracture ribs or the sternum. Large vessels of the heart may be torn. Patient can develop a tension pneumothorax. It is imperative that you reassess a trauma patient's chest region every 5 minutes. Pay attention to your lung sounds. Injuries to the abdomen. Solid organs may tear, lacerate, or fracture. Causes serious bleeding into the abdomen. A patient can lose a significant amount of blood in the chest and abdominal region. If you suspect internal bleeding and you're doing fluid resuscitation, our goal is not to normalize the blood pressure. So we want to keep it on the lower end, 90 to 100 for the systolic, or enough fluid to maintain a peripheral pulse. We don't want to dilute the clotting factors. You're going to use the largest IV catheter that can fit in that patient's vein. When hollow organs are injured, they may rupture and leak toxic chemicals. Healthy young adults are able to compensate longer than others for blood loss, maintain a high index of suspicion. Management. Trauma lethal triad. The lethal triad of trauma is acidosis, coagulopathy, and hypothermia. So you should never allow these things to develop, and this is what your treatment needs to be geared towards. So you don't want the patient to develop acidosis. And what you're looking for with the acidosis is we don't want them to start breathing slow, because that's a common cause of acidosis. If they start to hypoventilate, they're going to develop respiratory acidosis. We don't want coagulopathy to develop where the body start to use up the clotting factors and then they can't form clots anymore. And we don't want the patient to become hypothermic. So, major contributor to death in patients. Any factor that interferes with blood clotting will cause more blood loss. Aggressively seek to control all bleeding. Ensure IV fluids are warmed. Scene time. Limit unseen time to the minimum amount, should ideally be less than 10 minutes. Criteria to identify a critically injured patient: dangerous MOI, decreased level of consciousness, any threats to airway, breathing, or circulation. Type of transport. Several factors to be considered to use ground transportation. Be familiar with your local protocol defining indications for use of air medical transport. Criteria for air medical services. Distance to the trauma center is greater than 20 to 25 miles. Patient needs medical care and stabilization at the advanced life support level. Traffic conditions or hospital availability is an issue. Air transport to mitigate the effect of delay caused by EMS system. So because you were delayed on scene, you may have to request air transport. You have a multiple casualty incident, then this might be a criteria for air transport. Destination selection. Know the criteria for referral to a trauma center. Important to transport your trauma patient to the most appropriate facility that can deal with the emergency. Trauma centers level 1 through level 4. A level 1 trauma center has all the specialties that the patient will require present. And a level 1 trauma center is actually a teaching hospital. Even though it states that it's a trauma center, they do not only see trauma patients. A level 2 trauma center is similar to a level 1. They have all the specialties that the patient will require. The difference is a level 2 is not a teaching hospital. A level 3 trauma center has the specialties, but they are not at the hospital, right? So it has the specialities, but these persons are on call. So they may have to be called to come in to do whatever is necessary for the patient. Level 4 trauma center can only provide ALS interventions. Adult trauma centers and pediatric trauma centers are available in the States. Be familiar with how the American College of Surgeons Committee on Trauma classifies trauma care. So you can do some research on that. And that would bring us to the end of this chapter.